Welcome to Fertile Talks, the global podcast celebrating the diversity of fertility journeys. I'm your host, Dr. Yemi Famuyiwa. Whether you're just starting or simply curious, this is your safe space. In each episode, we will bring you expert insights, heartfelt personal stories, and the latest in reproductive health. Our goal is to break down barriers, tackle stigma, and provide support and hope. So whether you're in the Americas, Africa, or Asia, Fertile Talks is your companion on the path to parenthood. Thank you for tuning in and welcome to Fertile Talks. Now I'm going to talk about pregnancy loss, but I'm not even going to cover the full scope. I'm going to try and shed some light on some of the new fascinating discoveries being made in the field of recurrent pregnancy loss. So a lot is happening in that field, a lot of new technologies and treatments coming out. So that's what I want to shed some light on. Anyway, so today's topic is going to be on recurrent pregnancy loss. Yeah. All right, so I'm going to start with trying to define what is recurrent pregnancy loss. Recurrent pregnancy loss or recurrent miscarriages, which is the lay term or the medical term, is recurrent spontaneous abortions, occurs probably about 1 to 2% of women. Now, how many percentage of women actually have miscarriages? Identified miscarriages occur in 15% of women. When I put in there recognized, that means that a lot of women who actually have miscarriages are not even aware that they have a miscarriage. They simply may not even recognize. They may say, oh, you know what, my menstrual cycle was a week late or was a little bit heavier than normal, or they may not even recognize that they had implantation. So if you look at all pregnancies, probably about a quarter or slightly more is actually aborted. So human, which I think I've tried to express in this forum, is human gestation is not very efficient. What causes a pregnancy loss? So before we go into why does it happen over and over and over again in some women, I know there's one of the stars that came out today and said she actually had 9 losses and nobody knew about it. So they put on a brave face, they go on with their business, but it happens. So common causes that we know of include chromosomal abnormalities. Now, before I go into additional losses, additional causes, one of the things that happens is when someone has had a pregnancy loss, it increases their risk of having a subsequent loss. So if they've had one loss, that risk goes up to 20% in the subsequent pregnancy, all the way up to 43% after 3 losses. Other causes include genetic causes. And when I say genetic here, I'm not actually talking about the embryonic cause. The most common factor when someone has a miscarriage is actually an abnormality within the DNA of the embryo itself. Now, if you go about several courses or talks that I gave here, I think I had shown before how the egg and the sperm actually, how the egg is fertilized, and the DNA of the egg and the DNA of the sperm has to match and exchange genetic information before you have further cell division. Well, that match is not perfect. Some things get dropped, some things get added, and you end up with what I call a genetic accident. The medical term is aneuploidy. So that's the most common cause. Now, other causes include genetic causes in the parents. So if the parents are either missing an extra DNA or they have missing or have additional DNA, they may get what is called a translocation in the baby, and that can result in an abnormality that is not compatible with life. So that would fall under genetic causes. Other causes will be anatomic, such as someone having a septum that prevents proper implantation of the embryo, or they have an abnormally positioned fibroid, such as in the cavity. Other causes will be endocrine causes, if someone has thyroid problems, for instance, or they have diabetes. Autoimmune causes will be things like lupus, or they have the so-called antiphospholipid antibody syndrome. And then the vast majority are simply unexplained. All right. So what are the risk factors that may predispose someone to a recurrent pregnancy loss? Things such as thrombophilia, those are patients who have abnormalities in their blood. Antiphospholipid syndrome is when somebody produces antibodies that can attack the baby. Extremes of weight loss. So someone who is lean, has a BMI of less than 15, may have, if they have a BMI of say less than 25, right? They may have a risk of pregnancy loss of 14%. Extremely overweight women may have a risk of loss of 42%. So weight is very important. Patients who have high blood pressure that's uncontrolled. So someone who has recurrent losses, you need to do a complete history and physical. If they're hypertensive, that needs to be controlled. Cigarette smoking is not very good for pregnancy. So some people may miscarry if they're heavy cigarette smokers. Large amounts of caffeine, excessive caffeine use can also increase the risk of recurrent loss. Trauma, you can imagine would cause it. Malnutrition, and have to be severe malnutrition will cause that. Change that. And I think I already gave the juice away on this one, talking about miscarriage rate by BMI. So you can see someone, if someone is having really repeated losses and they're moderately obese, it might be a good incentive to help them work with trying to lose that weight. And if they can't do it through diet modification, I usually tell them to seek a physician weight loss program that might help them. Unfortunately, I didn't have time to show the anatomy of the uterus. As we all know, move that there, yeah. The egg, when it comes out of the ovary, gets picked up by the fallopian tube. It is fertilized inside the tube, and then the tube has this hair-like structure that moves like a conveyor belt that moves the embryo to the cavity. And it actually takes 5 to 6 days to get to the cavity. And while it's on that journey, it's dividing rapidly. By the time it gets to the cavity, it becomes what we call a blastocyst. When it gets to the cavity, there should be a conducive environment for it. Factors must come in place that allow the embryo to be implanted, meaning that the mother's uterus must accept the baby. The baby must be ready to be accepted. So there's like crosstalk that leads to implantation. So let's see if my little movie will play. You can see an embryo arriving in the uterus, and there are factors that come into place, and that embryo is subsumed into the cavity. And at the end of it, you see a little dimple where it was absorbed into the cavity. Now, what happens here? Okay, in the initial part of implantation, there's an inflammatory process that has to take place. Natural killer cells are involved, immune cells are involved, that allows a sort of initial inflammation to allow this embryo to tunnel through. Okay, see how it, and then you have the syncytial trophoblast, the blastocyst cells here, or placental cells here, that are tunneling their way in and implanting. While they are implanting, this embryo is a foreign body. It's like an allograft, right? There must be other crosstalk within the mother's uterus that prevents her from saying, oh, you know what? This is a foreign body, spit it out, not accepted, right? So there, and then when that initial inflammation occurs, there should be another subsequent dampening of that inflammatory process. So first you need inflammation to get in, then you got to quickly shut it down, because if you keep it inflamed, it's going to spit out, okay? And there are several factors involved in the crosstalk here. A lot is now known, well, being studied about what happens at this level. It's so critical. It involves immune cells from the mother. It involves the sperm as it traverses the cervix. It triggers a set of recognition of natural killer cells are triggered that starts to encourage the mother's immune cells to respond. And then there's another crosstalk that tells this immune cells to turn off. Now, one of the things that you might see is that we'll talk a little bit about what therapy is being proposed, trying to manipulate this critical phase and trying to keep that embryo where it should be. All right, so let's go to my next slide here. So I talked a little bit about what happens at the level of the uterus that allows the embryo to escape being destroyed by the maternal immune cells. This whole complex dance, symphony, ballet can be disrupted in certain patients where you have what is called natural killer cells. There are different types. There are some that is that you see in the peripheral blood, these are different from the ones that actually exist within the cavity of the uterus itself. And these are also separate from the ones that you may see in the vagina and the lower part of the cervix, right? So when you measure, and I know there are some places where they tell you, oh, yeah, just go for a natural killer cell assay in your blood. It is not measuring what's going on in the uterus because there are different kinds of natural killer cells available. Now, how can you sort of try to treat this? So a lot of this is being worked out by reproductive immunologists. Those are subsets of infertility doctors that choose to sort of investigate this really complex and exciting field. What are the things we can use? Now, remember that recurrent spontaneous loss related to immune factors is very, very, very rare, right? So it's not a common thing, right, that we're looking at. The vast majority will still be at the embryonic level. And again, I go back to some of the talks I gave before on how we can test the embryos to make sure they're normal, right? Oh, before I go, just a little analogy, right? When you have a pregnancy loss, there are two things that happen. A, the uterus recognizes an abnormal embryo and said, no, not allowed, right? That's what's supposed to happen. It's supposed to be a gatekeeper, right? Or the embryo gets there and it's normal, but then there are factors that are not conducive to accepting the embryo. How can you treat it? One of the things we commonly use is aspirin. If it's not contraindicated, someone doesn't have an ulcer or something like that, it may be used, minimal side effects and probably beneficial, especially if you have elevated CRP levels. Progesterone is usually one of the things we use a lot of, especially right after ovulation, because again, minimal side effects and effective in a subset of population. So it's readily available and beneficial for some patients. Now, the rest of the therapy is not what you would go to on a routine basis, such as low molecular weight heparin. There are some people that propose that the reason you have a pregnancy loss is if you form small clots underneath the placenta, such that in a hypercoagulable state, and you form microclots, there's not enough exchange of material between the developing baby and mom, and you can easily have a loss. So heparin, low molecular weight heparin, has some beneficial effects. And it also has some properties that enhance the growth of new blood vessels, which, as you can imagine, is important for proper placentation. Steroids may be used in certain cases, but you have to make sure the patient is not diabetic, not hypertensive, may be beneficial in someone who has losses maybe around the later part of the first trimester, and probably has to be in a program where a physician who's familiar with it is monitoring the use. Now, we're going into some of the more newer tech things out there. And also some of these are more experimental, so don't expect to see it mainstay. You will get them mostly within a clinical research setting. One of the medications being used is called tacrolimus. It's an immunosuppressive medication that is used to prevent organ transplants. It does have side effects, as you can imagine, and I listed some of them there. One of the things, what does it do? It tries to reduce the mother's immune response beyond the time of implantation so that the mother's immune response does not continue and proliferate and shift to a highly inflammatory state where the pregnancy is lost. You try to start it 2 days before you might, say, transfer an embryo in an IVF cycle and continue it on for like 16 days. That should say pilot study. And there are initial studies that are showing increased pregnancy with it. Other things that are sometimes used, again, should be used in more of a clinical research setting. There are centers that use it successfully, but they have carefully selected the patients that they choose to give this medication to. It's intravenous immunoglobulin. As you can imagine, it's expensive and it has to be monitored, but the studies are still inconclusive. There are some patients that have shown some benefit from it. As they say in the news, it's not ready for prime time because it's still being, they're looking at randomized clinical trials. Other things that may be used, more experimental things being used. Now, the mechanism of action of this one, TNF alpha, it's one of the newer medications coming out there that inhibits the Th1 immune response in the human body. This Th1 has been shown to be very active in patients that may have, say, arthritis, plaque psoriasis, severe asthma or atopic dermatitis, Crohn's disease, ulcerative disease. So it's a medication that's been investigated in all these immune-related diseases. And then people say, well, why, if we think that there's a subset of patients that have recurrent loss because of immune-related etiology, maybe we can now use the same medication in these subset of patients. So again, the studies are preliminary, but the idea is to reduce inflammation. Here, change this slide. Other things include intrauterine PBMC therapy. This is obtained from the mother cells. They're cleaned up in the presence of albumin and then instilled back into the uterus in a catheter. Again, experimental. The theory behind it is to, again, reduce the Th1 inflammatory pathway. Another thing that I did not have time to put in a slide is you might hear about intralipids being infused in certain patients. Intralipids are basically things like fatty acids or lipids such as soybean oil, olive oil, fish oil, some with medium chain fatty acids, and infused. Experimental, the mechanism of action again is to reduce inflammation, especially along the Th1 pathway. It's being used in research settings, university settings, where they have a controlled randomized trials. And I think that's where it belongs to. But I think one of the things that I got from preparing all this is, you see, if you have a chronically inflamed metabolism, chronically inflamed state of being, there are other diseases besides Crohn's, diabetes, heart problems. It can affect pregnancy. It lends more credence to what we've been talking about in this forum, is to try to maintain a lifestyle that reduces inflammation, such as plant-based diet, or if you're going to eat more fish that has, like, I like to eat my fish oil and in fish such as salmon and not necessarily in a pill. Anyway, so thank you so much. This is the end of my talk. Thank you for tuning in to Fertile Talks. We hope today's episode has provided you with valuable insights and support for your fertility journey. Remember, you are not alone. Now, if you have any questions or topics you'd like us to cover, please simply leave us a comment. And please don't forget to like, share, and subscribe with a friend. Your ratings, your shares, and your reviews are greatly appreciated and is going to help us serve more of our listening audience. Thank you once again. This is Dr. Famiyiwa.